So it's my pleasure to welcome you officially to this webinar, Who's Training the Healers? A Global Snapshot of Christian Graduate Medical Education. My name's Carolyn O'Brien, and I will be moderating today's webinar. I am Program Manager at Christian Connections for International Health and based in Chicago. For those of you that are new to us, CCIH is a global network of over 120 Christian organizations, as well as secular and interfaith partners committed to advancing health and wholeness. CCIH members work in over 190 countries globally, and those members include non-governmental organizations, church networks, Christian health associations, volunteer and product donation agencies, and other support organizations. Our topic today is Christian health training, especially graduate medical education. So to start, Christian health training institutions are at the heart of advancing Christ's healing ministry around the world. But recently, the full scope of graduate medical education, or what we'll refer to as GME, within this community has remained largely unseen. This webinar today is kind of a follow-up from a webinar and brief we published last year on health worker training institutions. Maybe we can have someone from the CCIH team post a link to that brief in the chat. And that looked at the full scope of health worker training institutions, but did not touch on residency programs and graduate medical education. So that is what we are diving into today and taking a deeper look at. In this webinar, CCIH and the Christian Health Asset Mapping Consortium, what we refer to as CHAMC, unveil findings from first ever global census of Christian GME programs in low and middle income countries. This landmark effort offers a revealing snapshot of a vital yet under-recognized sector, highlighting the breadth of institutions, programs, and countries engaged in training at the next generation of health professionals. Together, we'll explore what this emerging picture tells us about the current landscape of medical training, where programs are concentrated, which specialties are being prioritized, and where critical gaps in access remain. We'll also consider the potential ideas to catalyze stronger collaboration, smarter investment, and deeper shared learning across institutions. As health systems worldwide face increasing pressure and complexity, this conversation invites reflection on how the global church and its partners can more intentionally support training institutions, strengthening both clinical excellence and Christ-centered formation to equip a compassionate, skilled workforce for communities most in need. So the webinar today is going to feature 3 speakers, and I am pleased to welcome all of them. They have a variety of experience and expertise in Christian health education. So without further ado, if we can go to the next slide, we'll quickly just glance at each of their bios. Starting with myself as a moderator, I've been at CCIH for 6 years doing all things program related, have a background in international health, and I'm glad to be moderating today. Next. You will hear third from Dr. James Dua, who is the Deputy Executive Director of the Christian Health Association of Ghana. He leads administration, policy, and health service delivery across CHAG's network of 343 facilities. Next. The first presentation you'll hear from is from Dr. Gary Cloud and Dr. Ron Yee. Dr. Gary Cloud is a healthcare administrator with experience in hospitals, health management organizations, and community health centers and universities. Next slide. Last but not least, Dr. Ron Yee served much of his career as a clinician, medical doctor, and CEO of a community health center serving farm workers in California. And we are glad Dr. Ron and Dr. Gary are both CCIH technical advisors. And so we are glad that they have shared their expertise and helped to lead this work. So I will now turn it over to Ron.
Good. Thank you so much, Carolyn. Good day, everyone. I'm Ronnie again, a family physician, and I had the opportunity to work in U.S. clinical workforce development at the local and national level for the past 30 years. And this includes supporting the training, recruiting, and retaining over 35,000 clinicians serving in the 15,000 community health center sites. This is just a summary of the steps that Gary and I took to design this work and to really carry out these 5 steps to help us gather the graduate medical education and fellowships globally. So we went through these 5 phases, and we're moving from the friend sourcing or the validation phase into the curated maintenance phase. And so we'll spend some time discussing a couple of these phases, especially 2 and 3, but wanted to just note the friend sourcing and validation phase is really including networking and contacting in-country folks who work with these GME programs to see whether we're accurate, inaccurate, whether we've missed something. And that is a little bit more detail on the friend sourcing phase. But we'll discuss phases 2 and 3 a bit more as we go on. Next slide.
Yeah, in design of this, as you heard, we were following the health worker training initiative where we developed this extensive database identifying some 3,500 health professions, Christian health professions colleges around the world. So we decided to use a similar design since we're following up. And so one of the first questions we had to ask ourselves, are we going to organize this around the residency or around the institution? And we decided we would organize it around the institution itself. Next question we had to ask is, what is graduate medical education? And we decided to go rather broadly here and say that graduate medical education is formal, advanced learning. It's been regionally accepted and is ongoing. Our bigger issues then became the different names that are used for the same training or the different training that comes under the same names. And over time, we went from probably 100 different residency types as we had to combine them and condense them. Ended up with 45 we ended up with 45 of them. So a question would be, is this going to be an exclusive club? Are we trying to identify a limited number and no, we decided we wanted to be inclusive because we're trying to figure out what's happening in God's kingdom here with graduate medical education. Next slide, please.
Yeah, we wanted to, as we developed this database, we wanted to really be aware of sensitivities out there in the field. And so we started with some of these questions like, what is a Christian organization? So we really drilled down and we accepted Catholic, Protestant, and Orthodox denominations to really build this. What to call various Christian groupings. And really, as Gary mentioned, we were very open with that, and we really self-identified folks and organizations that identified as Christians, so we included those. Another question was, what is a country? You think of places like Hong Kong and Taiwan are a part of China, so what we did is we counted them as they designated themselves of what country they represented. And then really the names, we use those, as Gary mentioned, what they used. So we use the name and language given by the source as we found them. And then really another question, which has come up on other calls as well, is really we wanted to be sensitive about some are closed countries, there's persecution going on for Christian organizations. And so we asked partners and individuals, organizations, what we needed to be sensitive about. And there are some countries that may look like a lack of because they're not reporting to protect themselves. The database is protected and is only available upon request from CCIH. Next slide.
Yeah, so a little bit into phase 2 and phase 3, what actually happened. So what we did was use Gemini artificial intelligence to ask for each of the 134 lower middle income countries what Christian graduate medical education was there. Put that information in the database. But as we put it in the database, we also looked at the website or what was the public facing information for each of those organizations because we wanted to know what institutions, what clubs they belonged in. For instance, several of the residency programs in Africa, the surgery ones, were part of a Christian residency group called PACS. And so we made a separate list of these organizations that the institutions were memberships in, so that in phase 3, that became part of the work. In phase 3, we went to that list that had been developed and looked at what they were saying were members and checked out if they were Christian organizations or not to add them to the database. Then we took a look at the database and said, by country, and said, does this feel right? It seems like this place ought to have more going on. It seems like this place has too much going on. In those cases where we had questions, we went to a different artificial intelligence, went to Copilot, and we used deep thinking in Copilot to explore that country to then shore up the list that had been developed under phase 2. That's what we did in phase 3. Next slide, please. So we ended up with a database and are showing just one corner of it. I think there's 12 columns here. To the right of those 12 columns, when you guys get in to look at the database, you'll see 45 columns where there's a list of each of the 45 different types of residency or different programs that were there. But this is what it would look like when you get in, and you'll find it about the almost 2,000 lines deep and about 50 columns wide. I'll point out just one. If you look at in Argentina at the second one at Argentina there, Hospital Britannica, that happened to be the institution that had the most programs, had 45 different residency programs within that particular institution. Next slide, please. And I'm assuming that you guys have access or will make access available to you if you reach out to CCIH so you can look at that database yourself. This is squishier work than the work that we got to do with the health worker training institutions. Part of it is that there's bigger variations in what labels are used, what different parts of the world are calling say a radiology residency, what's included in that. Or some of them may have one focus on breast radiology. So there's these bigger variations, and there's also very significant differences in the way training is taking place in various parts of the world, from ones that are almost exclusively in graduate medical education doing clinical training, and to ones that are almost exclusively doing knowledge training without clinical practice as part of it there. So our labels end up being rather arbitrary, but we had to come up with some labels, and thus the 45 different groupings that we have there. Next slide, please. Oh, I should add that artificial intelligence is often artificial unintelligence, and we had to deal with that often. And we caught it at times just outright lying to us and trying to cover its lie. But so we had to work our way through that for this for the database that we have now. And it's imperfect, and that is the reason that the very important phase that we're in now is the friend sourcing, putting it in front of folks who are on the ground or understand, who've been to that particular residency program, and can say this is true, this is untrue, this is inaccurate, and help us clean it up and improve it from there. Yes, Ron.
Yeah. So where we are to date, what we've gathered is, as it mentions there, 275 institutions operating in 54 low middle income countries, offering 1,668 residencies and fellowships. And I think the more important thing for us all on this webinar is the last bullet point is there are no Christian graduate medical education programs identified yet in 80 LMICs. So we felt a real burden when we saw this number, and we believe this data reveals a challenge really for God's global church and educators. Graduate medical education is important, just as we focus on the 1040 missions window, there's really no one to reach people in the name of Christ, over 3.5 billion people, as we all well know on this call. And so we believe that graduate education and this training is one way to really address that true mission field. And so we really need kingdom partners and planners who understand and know how to successfully set up and run GME programs. And really, this is a call to us and a call to you all to share your best practices with others where there are none. So I'll have Gary break down this data a little bit more for us. Next slide.
Yeah, we look by regions. The database is most represented in countries by Africa, most represented in institutions by Africa, but most represented by programs or very residency programs themselves in South America. Next slide, please. So one of the indications that, or some institutions have quite a few residency programs, and logic would say that's probably, at least in part, related to the age of the institution, how much time they've had to add on to the residency programs. And so you can see there's about equal Catholic and Protestant institutions, but the Catholic programs is greater. More programs there on the Catholic side. Next slide, please. Well, the country with the most institutions was Brazil, and the most programs was Brazil. But interesting, the one with the most programs per institution is actually in Lebanon, averaging 19 there. Next slide, please.
So this map view of the distribution of Christian graduate medical education programs, as you notice, the darker colors signify the higher density, and as Gary mentioned, as noted in Brazil, India, and Argentina, and being the top three. And so the lower density regions really show a low number or a complete lack of Christian graduate medical education programs in the non-colored areas. So this just gives you an idea globally of what that looks like with what we found. Next slide. So this is a ranked bar chart. We included all 49 of the identified GME specialties that Gary noted on the Excel spreadsheet. And the top six were surgery with 11 subcategories, pediatrics, internal medicine, obstetrics and gynecology, family medicine, and anesthesiology. So you can see this broad distribution by the number of categories. I think one point of significance is that in our previous work on the Health Worker Training Institution brief, we noted a huge growth in undergraduate mental health, psychology, and counseling disciplines. And so what this indicates is that psychiatry and behavioral health in the graduate medication realm is becoming a much larger portion of clinical practice. And I've seen this on the clinical side that substance abuse and mental health issues such as depression and anxiety are really turning out to be a major factor in non-communicable disease control. And I think many of you have seen this in the field. So we have this arrow here. Is this an opportunity for psychiatry and the mental health related disciplines to really grow? And do we need to really look at that as an opportunity to share the gospel in many of these unreached countries? So, Gary, do you have any additional findings or experience that you saw in this area when we did the health worker training brief?
I'm going back to a time in my U.S. example for the community health centers in Arizona, where we asked the physicians, don't give us your code, what you're seeing, because we have the data. Just tell us what you actually see when people walk in the door. And the number one was otitis media. And number two was caries, which they didn't have at the time, the tools to treat. And from that, they began to open up dental suites as part of these health centers. But third was behavioral health. Number three treated thing they had, and they also, at the time, didn't have mental health providers to help deal with that part. And so those were both reasons that at least in my part of the world, that those other things are being added.
Yeah, and I think, on the clinical side, I saw with patient care and in the health center world, we had many chronic diseases that we could not get under control because there was a behavioral health issue there, whether it be substance abuse, depression, or anxiety. And so we saw in the US even that this is really becoming an issue and a challenge that we need to address along with our other care. So next slide.
Yeah, and this is a final slide. We got to be exposed to a whole variety of really cool things going on around the world. And I wanted to share just a few of them that were of at least of interest to Ron and I. One is this Santa Casa group, which is based in Brazil and Portugal, brotherhood of a couple of thousand institutions. 35 of those institutions are doing GME in Brazil, and they have over 200 residencies, those 35. But the way that they were organized was so, from a distance, from our look, was so cookie cutter. It looked very much like it was a co-op or franchise. I thought that was a great idea for his kingdom. That idea that we could take and plop down, let's put these 5 residencies in this organization is ready. Okay, let's put those same 5 residencies. We can cut and paste and move it to the next. So I thought that was really cool. There's Samaritan's Purse Medical Mission Fellowship, um, which um, which based on the definition we used ended up being included as graduate medical education. Why? Because it was formal and it was ongoing and it was accepted regionally, even if it didn't have, because I think there were like 50 institutions that they were working with. At any one time, several of those institutions may not have anybody in a fellowship at that time, but I think there's something for all of us to learn from what they have going on there. Likewise with Mercy Ship, as it's gotten much more engaged in medical infrastructure, which it's calling education, training, and advocacy, and it's formal training, ongoing training that has where it's got the ship parked there. Um, I think all of us can learn something from what the Vatican has going on. This was actually extra, it's not necessarily graduate medical education, it's extra education. In other words, some of the students in it may have graduated, and some of the students may not have graduated yet. But with a lot of talk, especially around CCIH going on about Christian formation, here's a Vatican organized collaboration for Christian formation of missionary positions that they do. And then Magis, which was interesting, a specific endeavor to help CHAD's developing GME infrastructure. Ron, I think we've reached the end of our slides. Does that sound right?
We have a few more. Yeah, just a
Oh,
couple
okay.
recommendations and prayers. We noticed with the database right now, there's potential issues with missing or inaccurate information. And this is back to our validation piece of talking to people in the field. Many of you on the call can really help us with this. If you notice some inaccuracies, please let us know. We want to be as accurate as possible. And finally, we have constant change that we need to really stay on top of and put some effort into this. We do have a referral sheet that if you want to be more formal about it and include more details, CCIH has a formal curation sheet that you can fill out to add or modify institutions that we have. Next slide.
Yeah, and this is a slide to a call to prayer. There's not anything we can do in his kingdom with more impact than us getting on our knees and interceding in prayer. Though we saw many institutions that had appeared to be having lost their first love, and they need prayer. And we also saw those ones that it would appear beginning to lose their first love. We need more prayer. And there's always this challenge in healthcare provision, Christian healthcare provision, with so many needs in front of us that we have to find a way to balance, being practicing care and practicing the gospel, and giving people hope for tomorrow, not only care for today. And so that's another one to pray about. And of course, Ron mentioned behavioral health care's role, and I think all of us the healing ministry of Christ ought to be asking ourselves what role that should be playing and what we're doing there. Of course, resources have been waning, especially coming out of the U.S., and people are at risk because of that. So please do pray. And then as we're doing this study, we're also hearing about wars around the world, and including places where we have Christian hospitals and missions and Christians workers there that are in the midst of that conflict and the fighting. And please pray for those also. A call to prayer for all of us.
Thank you, Dr. Yee and Dr. Cloud. That was such a great presentation of not only the data that they worked so hard to find, but also what does that mean and how can we be a part of this work moving forward? So I really appreciate that. I am going to turn it over to Dr. Dua now, who's going to respond to what Dr. Yee and Dr. Cloud just shared, and share a little bit about personal experience with the opening of a new medical school in Ghana. Over to you, Dr. James.
Thank you very much. And thank you, Gary and Ron, for that extensive work that you've done, and also for the visit to Ghana during the course of your work. So, Christian Health Association of Ghana is one of the influential service providers in Ghana. We barely have 5.5% of health infrastructure in Ghana, but in terms of health services delivery, we do between 30 to 40%. We influence policy in many areas. One of the areas that have been so difficult for us over the last few years has been doctors, getting doctors into rural areas where a number of facilities are located. We have 22 nursing training schools that are doing so well, who have churned out several nurses. And so every year, these nurses are given to government and they are posted to some of the public and Christian institutions, and they are doing so well. What we haven't had control over is the doctors. And we have tried as much as possible working with government. We have done a lot of influencing to get doctors to rural areas, but it's been difficult. So we realized that there are some facilities that sometimes doctors are not there at all. So over the last 5 years, we have been very intentional about what to do in terms of training of doctors. There are two main areas. One is pre-service training, and then the second is in-service training. We want to form physicians who are morally sound, ethically formed, who will be focused in rural areas where government-trained doctors will not be able to go. Next slide, please. So we have about 8 medical schools in Ghana. 3 of them are private, 5 public. All of them are located in the big cities of Ghana, Accra and Kumasi. And even though we have about 13,500 plus doctors in Ghana on the register, some of them we have lost them to the US, to the UK. And so as it stands now, we have severe shortage of doctors. We have less than 1 to 10,000 population, doctor-patient population. In some of the regions, actually, we have less than 1 to 17,000, which is really a big issue. And although we have a lot of medical schools, there are people who want to gain admission. The capacity in our medical schools is only able to take, of those who qualify, recently a study that we did, they're able to take less than 8%. During the recent Ukraine-Russia war, we noted that there were several Ghanaians who were training outside. So in Ukraine alone, there were over 1,000 Ghanaians training there as doctors. There were so many in Russia. We have quite a number of them in China and other places in Europe and in the US. So the idea was that why not? We have been able to do so for nursing. Why can't we do so for doctors? With all the facilities that we have, we're inspired by what the executive director of CCIH was able to do many years ago, his experience in Uganda. The fact that we have facilities that have equivalent of training and teaching hospitals. Why not form a medical school so that we can use our facilities to train doctors who will be compassionate, who will be Christ-centered, with integrity and rural focus. That informed the formation of our medical school. Next slide, please. And so we have chosen at the moment one of the three oldest hospitals within CHAG, which is the Holy Family Hospital in Brekum. Is located down south, close to the northern side, around the border of Ivory Coast. The hospital is the third oldest facility within our network. It serves about 130,000 patients every year. They have nearly 600 staff. It has very strong clinical background and training. In fact, before formal training of anesthesia, nurse anesthesia training started in Ghana, they were training nurse anesthetists on the job, and a lot of nursing on the job. They have nursing training school, a midwifery training school as well. Next slide. And so, as I said, we want to form and train people of faith, grounded in ethics, of course, very competent in skill delivery, who are very community-oriented. The government many years ago started a focus like that, where they started a medical school in the northern part of this country when doctors were not being accepted to those areas. But unfortunately, the intention has been defeated because when doctors are trained, they end up coming back to the big cities. And so our primary aim is that we will train people and give them community-oriented, rural focus where they will stay. What we are going to do is to partner with some of the universities here locally. The Catholic Church, I'm happy that in Gary and Ron's work, among the denominations that have large number of institutions and programs was the Catholic Church. It is so in Ghana in terms of institutions. So the Catholics have a university that is forming the academic institution for our medical school. And we are also going to partner a number of international institutions in this work. Next slide. So already we have begun a number of facilities. We are almost done with our anatomy lab. We have some lecture halls, some being used by nurses. We are creating simulation labs. We will start small, as it were, and here slowly. We'll start with a student population of about 55, and we assume that if even 5 drop out, in the end, we'll have about 50. One of the challenges that we have noted with the current public education is the huge numbers. During my time in medical school, we were very few on one bedside. We were just about 5 people. Now we have sometimes 40 people. And if we are short, you will not get opportunity to have hands-on education. And so we'll start very small. The implementation is aligned to accreditation milestone, Medical and Dental Council, and Ghana Education, tertiary education accreditation processes. Our estimate is that with the current infrastructure that we have, the amount that we need to add up will be about $9 million US. Next slide. And so it's a noble vision. We have had sleepless nights about it, but we believe that with all the work that we have done over the years in terms of influencing care, where about 8 million Ghanaians benefiting from our services with only 343 institutions, we believe that the medical education is really key for us. And as Ron said, graduate medical education is such an important way of a Christ healing and faith service. And so we need partners to support in terms of infrastructure and teaching facilities. Obviously, where we are starting from, some people live on less than $1 a day. There are families who are living on less than $1 a day. And so to create access for everybody, it will be good to have some form of scholarship for people who are coming from poor backgrounds, people who don't have the means to pay. We also need partners to strengthen faculty development and research, and then in advancing Christ healing ministry across Africa, especially with the missionaries who are working across the globe. I'm happy that the work highlighted the work of Mercy Ships and now there's some key missions across the world. Next slide. I think that's the end of the slide. Thank you very much.
Thank you so much, Dr. Dua. On the screen here, before we close the slideshow, there's an email, mapping.consortium@ccih.org. If you have any follow-up questions after this or after reading the GME brief, you notice some missing programs or institutions, please do email mapping.consortium@ccih.org and we will follow up with you and make sure that information is included. So we can close the slide deck now and spotlight our speakers because we will be going into a time of question and answer and discussion. So I already see a couple of questions in the chat. Let's start with this question here. Dr. Dua mentioned the medical brain drain from LMICs. How can this consortium build vision in health workers to engage in sustainable service in the gaps that remain, including the 80 LMICs which do not register any programs as mentioned by Drs. Yi and Cloud? Who would like to start with that question?
I believe it
Well, I
starts
can
with
share
prayer.
some experience.
You first, James.
We used to have, before the year 2000, we used to have a lot of brain drain because we didn't have opportunities for residency training and specialist training in Ghana. Then the government started residency training and formed the Ghana College of Physicians and Surgeons that started training specialists in medicine, surgery, pediatrics, and some of the other minor specialties. We saw a downward trend. In fact, there was a significant shift of people traveling elsewhere for specialist education to train locally. And from that time, we have had increased number of specialists. So I guess one of the ways would be to encourage and support countries, especially in lower middle income countries that have these graduate medical education programs, to train specialists. I guess to retain a lot within. I hope this helps.
Thanks, Dr. Dua. Dr. Cloud, did you want to add anything to that?
I was going to say it. I think, every victory in his kingdom starts in prayer. And so all of us ought to be on our knees. This should hurt. This is shocking information. This should hurt in the midst of what as Ron said, 3.5 billion people who've not had a chance to hear the gospel, and 4.5 billion people, according to WHO, do not have adequate health care. This should hurt, and we should be doing something about it. And I mean everybody on this call, and maybe it's a clarion call for CCIH to keep this at the front of their agenda.
I think one last thought too, as Dr. Dua mentioned, I think if we can get some of the training out in the rural areas, underserved areas, we see a similar parallel example in the community health center world. We saw that when we had students and undergraduates train in underserved areas, they kind of caught a vision. That's what happened to me, how I ended up working with farm workers and their families in rural California, because I had a rotation there. And so I think if we can expose them to that, combined with what we found when Gary and I visited Ghana, we went to, I think, at least 10 organizations to find out what they do to train, spiritually form their students, not only clinically, but spiritually. We offered the question of, are you looking at who you recruit? And this would, extend into graduate medical education is, can you recruit the people from those areas so that they can have the additional training? And so they already have the heart for their communities, their villages. And so if you can train them, those are the ones that are more likely to go back and serve their communities. So I think the combination of experience and then who you choose to go into your programs can help move that dial for the brain drain.
Thank you. Thank all three of you for those answers. I see that there's some additional questions coming in the chat, and we're on a meeting format in Zoom, so it's less formal. If you would like to come off mute and ask your question, just raise your Zoom hand and I can come back to you. In the meantime, there is another question here. Dr. Dua mentions a key factor in the quality of education, student to teacher mentor ratios, which argues for engaging and recruiting hospital and clinicians that are working at perhaps somewhat smaller teaching sites nearby the Index Medical School graduate training site. That kind of builds off what you were just talking about too, Dr. Yee, but if any of you would like to go into more detail on that question, mentorship and teacher to mentor ratios.
Yeah, so typically what you find in the existing medical schools, public medical schools, is that all the students are attached to a teaching hospital. And because these have finite number of beds, they are forced to have so many of them around one bed. The advantage that the church and Christian health associations have is that in our case where we have over 340 something plus institutions, it is easier to spread. So you have, and that's the experience that we got from what Doug Fountain shared about Uganda. So you have a Catholic facility here that is so good in orthopedics, another Presby facility so good in obstetrics and gynecology, and Methodist facility good in medicine. So you have students rotating, and our medical school has a number of sites. So you have students out of the 50, you have maybe about 10 rotating in different rotations across different hospitals. That way we have smaller sizes per one bed, and different experience from different institutions.
I think one thing that when Gary and I were in Ghana, we noticed the interdenominational work, and I believe CHAG, Dr. Dua's organization in Ghana, works with 34 different denominations. And I think as we learn to work together for the sake of the gospel and see the needs of each other, I think, he talked to organizationally where they have the rotations, but I think interdenominationally, we can help each other with those staffing ratios and trade skills and expertise. I don't know what that looks like or how we do that, but that's something we've been praying for, that this work in GME and in undergraduate work will help bring together our denominations for the sake of the gospel to really work together, which has been very fragmented and isolated and siloed in the past. And so we've been praying that God would use this to combine his church globally to focus and I think share resources, faculty, whatever that need be amongst each other.
I'll add Ron and I, in our previous life, where he was and I was involved in starting colleges to prepare healers to work in community health centers, embarked on a strategy to pull students away from the big central teaching locations and move them into the communities where of need were. The communities were very receptive to having students there. So we had 49 community campuses, miniature programs, and there's a version of that Dr. Dua is involved in doing, but I think there's a lot to be gained from pulling out of just the huge teaching hospital and getting engaged in where the needs are and raising tomorrow's healers up where the needs are.
Thank you. I've seen a couple of questions in the chat about CCIH membership and how to connect with other CCIH members. There is also, so I will let Molly Bond, who's our membership engagement manager, answer those questions, but I did want to touch on a piece of Janelle's question. Is there a working group for this? CCIH just launched a task force. Was that just last week, I think, on Christian health worker training, really focusing on quality and connection, and how we can continue to work on these issues. That task force has a plan for the next 2.5 years to address different aspects of this. So that's just getting started. We definitely at CCIH want to put a lot of emphasis on this area and filling in some of the gaps that we've seen. I'll just also touch on another question from Amy Hewitt. Is there a list you can share of the 80 LMICs that do not have access to GME? I think we would definitely be able to come up with that list and share that. So maybe we can do that as a follow-up from this webinar, as we'll be sharing the slides and a recording and links to both of the briefs about this work. Maybe that's something that we can pull together too. So thanks for asking for that. We have another question here in the chat, and thank you for Mona. As a reminder, this webinar does go 15 minutes past the hour, so we'll have a little bit more time for Q&A. We understand some people will have to drop off right at the hour, but we'll stay on for a little bit longer for those who can. One of the issues I've heard of with Christian training institutions that receive funding from their country governments is that their students do not always come from the same faith tradition, and they are receiving more pressure from their governments to follow the same curriculum as secular training institutions and remove aspects of faith. Are others experiencing this? And also, are there less Christian health facilities willing to take students from these Christian training institutions for their practical training, different depending on the country, which is another challenge for Christian training institutions? So kind of a meaty question there. Who would like to jump in first?
I'll volunteer Dr. Dua. I know he has stuff going on in this area.
The on-the-ground experience.
Yeah. So, well, Mona, you are right. So of course, when government makes input into your funding, it gives the government a big say. But our experience is how the leadership engage, and especially putting formal documentation in some of this engagement. So in Ghana, we have a Ghana Tertiary Education Commission that requires that basic minimum items on training be there. And so that minimum, you have to have it on your curriculum. But we have gone ahead and have a memorandum of understanding with government that when it comes to management of our institutions, both service providing institutions and also training institutions, that lies within our domain. And they need to understand that. And formally, we have signed with government. And so we add other areas in the curriculum. In our case, we are thinking of making strong ethics. So we have some of the Catholic priests who have PhD in ethics who are going to be part of this. Some of the programs that we are doing already, even in our nursing training schools, we have time, 2 weeks, 3 weeks, that we send nurses to places that are training people in cervical cancer. That is not on the general curriculum that government advocates, but in our nursing training schools, it's been added. So we have some freedom to add. Regarding facilities asking for trainees, the experience here in Ghana is that even the public institutions and private institutions are very much interested in staff who are trained by the missions. In this case, we have increasing number of people who require nurses from mission trained or Catholic or Presby trained nursing schools. And we believe that even with the doctors, it's going to be the same situation. The others is about people from other religion. It's been a very thorny issue for us, especially for those who have been trained already and coming to provide care. But when it comes to medical education, I don't know how the others see it, but for us, we see it as a real opportunity to influence people and their behavior. We have people in parliament who are not Christians, but they will want to ensure that all their children are training in Christian institutions. And likewise for doctors at the house officer level, they will insist that all their house job, they do it in Christian institutions because of the values that we espouse and because of how they turn out. So it's a real opportunity to take people from other faiths. Of course, it gives us other opportunity to convert them as well. Where I worked many years ago in the northern part of Ghana, it was predominantly a Muslim community. 99% of the people were Muslims. And we had a lot of them who are nurses, Muslim nurses, were coming to provide care. We influenced them because they have devotions with us. When we are having our morning devotion, they serve with that. When we are going for our outreaches and preaching moments, they go along. It's so, even though it's a challenge, we see it as a big opportunity to turn people into the Christian faith and also to influence their behavior and conduct.
I do want to add on to that too. You know, in our experience in Ghana, we also got to witness Dr. Dua and his CEO, Peter Yeboah, at the Christian Health Association of Ghana. They are very data oriented and they understand how the government needs information and data to prove that this care is going on. Right now, CHAG is over organizations that care for a third of Ghana's people. So 12 million people are cared for by CHAG organizations. They understand the whole relationship and the need for government to say, this is actually having good outcomes. And so CHAG is very active in collecting data and looking at outcomes clinically and financially. And so that is all part of, I think, working with the federal government is we can't just come in and say, hey, we have good intentions and we care for people and love them. CHAG is actually proving it. And I believe what they've seen so far is they actually are providing better care than the secular state-run institutions. And so that is part of the makeup of CHAG. And I believe in this world now, how we work with governments is that we need to give them what they need also. So when the parliament has a discussion, they have data behind it to say, these organizations that work with CHAG are performing well financially and performing well clinically. Therefore, we need to continue supporting them and even expand what they are doing.
Great. I'm just seeing there is so much information coming in the chat, some really good comments and some insights from people that are really heavily involved in this work. So just encourage everyone to just keep an eye on what insights and wisdom are coming up in the chat. There's a question here about are any FBO institutions, including community health worker training to upskill traditional midwives? If so, can you share the curriculum? So I see there's a reply of some connections happening there, so I'm glad to see that. But I just wanted to mention, because this came up earlier in the chat, someone asking about nursing programs and PA programs. Those we tried to capture in the previous brief and webinar that we did on health worker training institutions, where we kind of looked at different types of nursing programs and midwife programs, as well as a lot of different other programs outside of your traditional medical programs. So please do take a look at that. But I wanted to raise this issue too for this group of, what about curriculum and sharing curriculum? Is that a possibility between institutions? Is that a possibility between GME institutions? I saw even a note from here that there's a spiritual curriculum that the Pan-African Academy of Christian Surgeons and the Christian Academy of African Physicians supports. So just wanting to speak or hear from maybe especially Dr. Cloud and Dr. Yee about what are thoughts and visions about curriculum sharing and standardization and some of those pieces that hopefully the task force will touch on in the next couple of years. I think this might have to be our last question of the day, but please do keep sharing your comments in the chat.
Dr. Cloud.
It would be great if institutions would share their curriculum. I think it often has to come from the institutional level because of faculty, love of what they've put together. But that was the example that I was trying to share from that from the group in Portugal and in Brazil, where it would appear that they've worked together and accomplished much by working together. And of course, our Christ would have us work together as opposed to independently and acting like we're alone.
Yeah, and I just really quick answer your question, Carolyn. I think PACS and CAP have an excellent discipleship program already set up. Loma Linda has a 3-year discipleship course built into their curriculum for their medical students and residents. And so I think learning what's already in the field is our challenge on this task force. Is let's take what's already out there and then create a framework that can be adopted to different denominations for their needs to put in their particulars. And I think that's the direction we're headed. But we definitely want to see what's going on in the field already, which has been successful. We don't need to redo all that work. We are very thankful for what has been already done on spiritual formation.
Excellent. Yeah, part of this work and the task force is really trying to bring people together from all parts of this this topic and this area, so that we're not as much working in silos as we are working together, which can be a trap for the global health world. So I'm glad to have you all here and engaged in this work as well, so we can continue expanding that partnership and collaboration. We are nearing the end of our webinar today. I just thank you all so much for your engagement and participation today. I would like to give each of our speakers a chance to share a closing thought or encouragement with the group. I just wanted to provide an opportunity if Doug Fountain, if you wanted to say anything or add anything to what's been said today, as you have been key in getting this work off the ground as well.
Thank you. I'll just say something really quick and really appreciate everybody being part of this. And thank you to Dr. Dua, Dr. Cloud, and Dr. Yee for leading us through this amazing time. We have the chance to shape the future of Christian healthcare globally. And I really sincerely believe that the people here and the work that we're doing together is actually going to transform us for a future. So thank you for this webinar, and thank you for everybody who participated. Now to closing comments.
Great. Let's start. I'll just go in order of how I see people on the screen. Dr. Dua, if you'd like to start us out.
Right. So thank you, everyone. I think education offers a great opportunity for multiple areas. not only the knowledge that we transfer, but also in terms of character service. And this is where we have, as faith community, especially in low and middle income countries where the gaps are so huge, where we have doctors and nurses living, we have a very good opportunity to strengthen what we have in terms of graduate medical education and to start more in areas where we don't have. I'm happy that somebody was asking a list of places where there's no graduate medical education, but for places that exist, that are also starting, it will be good for the faith community to start. It's a biggest evangelistic platform, more than what crusades have ever reached out to. And I guess we stand to touch more lives, influence society and communities if we do invest in Christian medical education. We are available to work with any partner that's ready. Thank you very much.
Thank you, Dr. Dua. That was very encouraging. Dr. Cloud?
Folks on this call have committed themselves to Christ healing ministry. That's tough work. Thank you for doing it.
Beautiful.
And I'm encouraged, I think, with the basis of prayer, people on this call and others that we've come into contact with really have the capabilities to pull this together. And I think Gary and I are still drawn by a couple of the burdens that CCIH, Carolyn and Doug specifically brought to us when we first met them a couple years ago. And they had a real burden for the theology of health biblically. What does that look like on the front lines? How do we integrate body, mind, and spirit? Clinical training and spiritual training? And secondly, how do we use all this work to bring unity in God's global church? And I am so excited to see the steps that have been taken. We have a lot of work to do, and a lot of people on this call are involved already. But I really believe this is the call that God has called us to, and we are all part of this. So I think medical education, whether it be undergraduate or graduate, can be one of those tools that God can use to really bring the theology of health into our practice, but also unity for God's global church. So I'm excited for us to work together. We're rolling up our sleeves and we're ready to go.
Excellent. Well, just a bit of housekeeping, and then I'll turn it over to Dr. Cloud to end us in prayer. Once the Zoom webinar closes, you'll get a 2-question survey. So please take a second to answer that once the Zoom closes, so we can continue to improve on the webinars and that CCIH puts on. And just thank you again for being here today. Over to you, Dr. Cloud, to close us out with prayer.
All right, let's pray. Heavenly Father, give us your heart. We know you're hurting when people are suffering. We understand it's okay, and we've not done enough to spread the gospel. We've not done enough to engage in the healing ministry of Christ. It's not okay that 80 lower and middle income countries have no Christian graduate medical education. We commit ourselves to do something about that. And not only that, to work together as your body, as your unified body, and doing something about that. We make that pledge here today. Thank you for all you've done for us. We pray this all in Jesus' name. Amen.
Amen. Have a good day, good evening, good night's sleep. We'll see you again soon.
Thank you all.
Bye, guys.
Hey, everybody.